is it more common in obstructive sleep apnea or obesity hyperventilation syndrome?
Okay, well, thank you, Dr. Hani, again for the invitation. Yeah, it's more with obesity hyperventilation. And again, obesity hyperventilation, most of the time, will also have a degree of obstructive sleep apnea. The reason is people with obesity hyperventilation are more hypoxic, and there is always a strong relation, as you know, between chronic hypoxemia and pulmonary hypertension. So yes, it's more in patients with obesity hyperventilation.
And I think you showed in your case, the patient with the severe sleep apnea, the hemodynamics were not very bad. In fact, the cardiac index was preserved. Yeah. So I think when we see patients with right-sided heart failure, low cardiac output, and reduced, increased PVR, we have to look beyond the sleep apnea. I mean, there's obviously, we've seen patients who have other causes of pulmonary hypertension on top of which they have sleep apnea. So I think this is a very nice case to show that you just don't stop there. You have to keep going, especially if the hemodynamics are suggesting otherwise.
I agree with you.
But also we have to do sleep apnea evaluation in all patients with pulmonary hypertension because of the frequency that you mentioned. So it's a complex algorithm for the diagnosis. And you really can't skip any of the steps as well.
And as well, if you allow me to add, treatment with CPAP will also help and contribute to the treatment and lowering the pulmonary arterial pressure.
Absolutely, absolutely, very well said. So there's a question here from, I think, Dr. Wa'il Al-Naim. He's one of our lead clinical pharmacists at Sheikh Khalifa Medical City. So a question about patient support programs to help access to expensive PH medications. Do we have enough of these programs in the region? So I don't know if yourself or Professor Majdi would like to start. I have a certain perspective myself. I think Dr. Majdi's connection is weak. So I'll just give my small perspective here. So I think since 2019, the various industries have been very helpful in trying to support the patients through a specific patient support program. As you all know, pulmonary hypertension medications are orphan drugs and therefore quite expensive. And anywhere here in the UAE and in the Western world, there's a lot of support for these patients through charities. So utilizing a specific organization that is actually approved by the UAE Ministry of Health, all of the pulmonary hypertension medications are now currently available through a patient support program that covers anywhere between 75% up to 100% of the cost of PH medications. And we really should not inhibit our patients from being on PH medications because we have this very powerful charitable foundation. The second thing that I actually think this is, speaks to the same point is that, over the last 7 years, we've worked really tirelessly to help support these patients through the Center of Excellence. And we have, of course, been accepting patients from every hospital, everywhere in the UAE, from the Northern Emirates to Al Gharbiya, from Al Ain to Dubai. And, these patients are ultimately very young and very sick patients. So the earlier we get the referrals to the hospital, the better. And in fact, it's even better if they can come to the, to the clinic, because the designation for these very high-risk patients is actually supported. We're able to accept the patients in transfer or with the referral, really regardless of the kind of insurance they have, expats and non-expats. And I think this is really an important breakthrough in the treatment of pulmonary hypertension. And I have to give a lot of credit to the Emirates Thoracic Society, particularly Dr. Ashraf and Dr. Mohammed, who couldn't be with us, Mohammed Al-Houqani, for including pulmonary hypertension in the list of severe life-threatening diseases that is supported by the Abu Dhabi Department of Health.
Hi, Hani, can you hear me?
Hi, this is Dr. Khalid Saleh. I'll just introduce you real quickly. Hello? Yes, Dr. Khalid, Khalid? Khalid?
Hani?
Yes, I can hear you. We can all hear you. Khalid, you're muted. You're on mute.
Yeah, hi.
So I'd just like to briefly introduce my dear friend and colleague, Dr. Khalid Saleh. He's the other half of the pulmonary hypertension clinic. As you know, I'm a cardiologist, he's the pulmonologist. So basically we have the heart and lungs in one clinic. Khalid, go ahead.
Yeah, hi. Thank you for giving me the opportunity to contribute. Thank you, Dr. Houqani, for this very elegant talk. Nice summary. Can you hear me?
Yes, go ahead.
Yes,
Okay.
and you're welcome.
Yeah, thank you. So, I mean, I've been working with Dr. Hani on PH now for the last 2 years. And as you know, obstructive sleep apnea is also dear to me. So I'm interested in this topic. As you mentioned, Dr. Houqani, the bottom line is the correlation. The nicest study done on this by, I think, Mohsini or something like this, because I don't have the articles in front of me. They studied 200 patients and they found the correlation for pH and with the sleep apnea is not the AHI, but the number of minutes with desaturation, which highlights the importance of hypoxemia. So if you have a patient with the OSA, most of these physicians, they look at AHI. They never really look at the hypnogram to see how much there's desaturation. So if somebody has like pulmonary hypertension, but they don't have desaturation, we really need to look at the diastolic dysfunction, pulmonary venous congestion. These people actually, they may have an early or even missed HFpEF, heart failure with preserved ejection fraction, causing the pulmonary hypertension if they don't desat and they do have evidence of pulmonary hypertension on echo. Because, I mean, early detection of HFpEF or diastolic dysfunction without florid heart failure is very important to treat early on. Because Hani and I, we see these HFpEF patients all the time. I mean, their numbers are in the hundreds. So it's kind of like a point that I would like to highlight, and that because I've seen it so often. And I don't know what's your opinion, Dr. Houqani, on this? Do you see that too?
I cannot agree anymore. So basically, we should not look at AHI as one variable. AHI represents the number of apnea, hypopnea per hour of sleep. But as you just mentioned, it's not correlating most of the time with a pulmonary hypertension severity or even what type of pulmonary hypertension. And many of them, they could have I would say type 2, more of a hypertension not related to the pulmonary arterial pressure, but it would be more of pulmonary venous pressure, as you just mentioned, and diastolic dysfunction. But yes, it is correlated with a degree of hypoxemia. And one thing that you could, if you don't have the hypnogram, you could see the mean oxygen saturation during sleep. And many of them, they're the one with hypoventilation, you'll see the mean oxygen saturation below 90% most of the night. And that would be correlated with more of pulmonary arterial hypertension.
Yeah, nice. Yep. So yeah, it's very fascinating topic because the number of patients with OSA and pulmonary hypertension is very large, and we really need to work on both fixing the sleep apnea, the hypoxemia, and other comorbid condition like LV diastolic dysfunction, which I believe most of these people have hypertension and probably have diastolic dysfunction.
I agree with you.
There's a couple of questions around the same topic. I think we started a very interesting series of questions. So from Dr. Nasser, should any patient with pulmonary hypertension during the workup undergo sleep apnea testing?
I would highly recommend screening them for sleep apnea, especially if they have symptoms of, I would say if they have symptoms of obstructive sleep apnea. So you could do the stop bang if their BMI is high, if they're snoring, if they have witness apnea, you should do the sleep study. But if it was an 18-year-old young lady who's thin with no symptoms, probably you don't have to. So do your screening. You could start with a very simple of stop bang, and if they have symptoms, I would highly recommend doing a sleep study.
I totally agree. I think the common phenotype that you and Dr. Khalid were discussing earlier, which is the group 2 pulmonary hypertension, Patients with diastolic dysfunction, with metabolic syndrome, morbidly obese, these patients have pulmonary hypertension. Sleep apnea is multifactorial. And in the presence of diastolic dysfunction, sleep apnea is strongly suspected. As a matter of fact, it's one of the reasons why we think they have pulmonary hypertension. So you have to look at the phenotype as well. It's not just a checklist. There's a question from Dr. Mira Ibrahim. Isn't hypoxia reflected upon AHI? I think you've sort of touched upon that, but maybe if you can clarify that, or Dr. Khalid also, if you guys could clarify that.
Yes, so it's not always, see, the way where some patients with severe obstructive sleep apnea, you'll see their oxygen desaturation going up and down, but they go back to their normal. And most of the night, they will be satting above 92 or 93%. Whereas people who are hyperventilating or they have the overlap syndrome, you'll see that they spend most of the night with a low oxygenation. Yes, they would have a high AHI, but even when at the time when there is no sleep apnea, their oxygen desaturation or mean oxygen saturation during sleep would be low. So these are hyperventilating during the night and they're hypoxic. And even when they wake up, walking around, you do their oxygen saturation, it could be 92, 94. This is not normal. It's not normal to have a 92 and 94. And unfortunately, they're missed. They go around and everyone is checking them and they think it's normal, but no, it's not normal. This is what should trigger sending these patients to further investigation.
Thank you. That's really an excellent way of describing that, because again, the issue of having a clinical suspicion and diagnosis is really the Achilles heel of this disorder.
Yeah.
And unfortunately, people attribute these patients to everything from depression to anxiety to anemia to bronchial asthma, and of course that leads to delay. So thank you for highlighting the diagnostic criteria. There's a couple of interesting questions from, from Dr. Mildred Fernal. Long-term use of bronchodilator or Serotide, does this cause pulmonary hypertension? I think we know the answer is no, but this is an important clinical point because sometimes people confuse shortness of breath and empirically treat with bronchodilators when in fact the diagnosis is really pulmonary hypertension. So I think if we have unexplained shortness of breath and dyspnea without respiratory disease, without wheezing, without cough, let's think of pulmonary hypertension beyond, the obvious, because really, this is going to be a life-saving intervention. A question again about how do you make cardiologists interested in doing right heart cath? Well, the way I do it is by lectures like this to cardiologists, but I think it's important to realize that, a lot of us as cardiologists read echoes, but we don't focus on the right ventricle. Like Professor Majdi mentioned, we just look at the left ventricle or the left atrium or the valves and we just close it. So I think if you're referring a patient with dyspnea, shortness of breath, edema, chest pain, syncope, and the echo report comes back without the right ventricle or right atrium, you have to turn back and tell the cardiologist, this is an incomplete echo. I need you to look at and describe the right ventricle. The next step is to realize that the right ventricle on echo is not the only diagnosis, and right heart cath is a very simple, minimally invasive procedure that actually gives you a very important diagnosis. Any other comments, Dr. Mohammed? Khalid, if you have any comments, or Dr. Majdi, if he's back on the link. All right. One question on the chat here from Dr. Al-Muteri about sickle cell disease and pulmonary hypertension. So this is a very important entity in the Middle East, in the UAE. Sickle cell disease and hemoglobinopathies are unfortunately quite common in our area. And I think Dr. Majdi actually is the expert on this. They've actually written up a series of patients and multiple presentations on sickle cell disease. So what we used to call the lung crisis, if it's repetitive and frequent, can actually give rise to significant pulmonary hypertension, and there's specific treatment entities needed. Oftentimes, if you do a ventilation perfusion scan, you're going to see these multiple perfusion defects that are distal. They're not actually thromboemboli, these are sickle emboli that are going distally. So it's important in these patients to consider exchange transfusion, to manage the sickle cell disease more carefully with the hematologist, but also pulmonary vasodilator therapy becomes important before the right ventricle fails. And in this case, we actually do not use sildenafil PDE5. There's specific data on the use of riociguat, which is soluble guanylate cyclase stimulator, that actually does not itself promote sickling, but treats sickle-related pulmonary hypertension. So again, one of the things that a center of excellence should do is to have a multidisciplinary team, including a hematologist, a rheumatologist, obviously a cardiologist and pulmonologist, and other subspecialties.